Here a bit different topics. Definitely ECG. ECG actually not mathematics, probably a bit philosophy. So far, my understanding, it not always fit with any always in a single diagnosis. Sometimes ECG might have different diagnosis, and it is seen that 1 to 2%, 6% of the patients having normal ECG with myocardial infarction that might have. So, first, my number one case, 65 years, women, admitted in came to our ER department with abdominal pain. And she has comorbidities, diabetes mellitus, hypertension, and CKD, and definitely having family history of heart disease.
Actually has
Initial
already
sample
been
was
spoken by Dr.
negative, and
Rakesh
later on
Yadav.
it was found
So because the
5,000. Creatine level was 2.6. This is the ECG in emergency department. So you can see there is ST division in AVR, and most of the leads having ST depression, and definitely patient having abdominal pain. So there is a dilemma whether it is myocardial infarction or acute coronary syndrome or anything else. So diagnosis could be left main coronary artery occlusion or a very proximal disease before major septal branch or severe TBD, or can be benign in SBT, or even this is atrial fibrillation, fast ventricular rate. So without having any coronary artery disease, this could be a benign condition. Echocardiogram shows there is regional wall motion abnormality, 45 to 50% ejection fraction. So there might have something in the coronary. So we have taken the patient to cath lab. Right side, there is no significant diseases. In the left side, you can see the LAD osteal lesions, but still there is a TIMI flow too. So there is two lesion, another is in the mid segment. So we fixed up the lesion with two stents. This is the mid segment stent, and this is the proximal with osteal. So this is the ECG after PCI. So one can miss the ECG if it is not initially taken care. So and it is definitely very proximal disease can lead to patient into cardiac arrest, and sometimes it is very difficult to take the patient to cath lab. Case 2, Mr. Emmer, 75 years, male at OPD, just came to me without having any complaint to do an angiogram. I just advise patient to do, and patient is non-hypertensive, non-diabetic, and non-smoker even. And I advise to do a cardiac vaccine instead of doing coronary angiogram. So this is ECG at OPD, echo normal, ATT, there is no significant, it is negative. This is summary of the ATT, so you can see there is no significant changes ECG. But still, patient demands to do an angiogram. Patient's brother with him, he came from very remote area. For the last 2 months, he's seeking to do an angiogram. So what should I do? Later on, I agreed to do angiogram, and next 2 days, patient did not come to me, and on the third day, patient came to me to do angiogram, and I did angiogram. So right side is normal. See the left side. LC is totally octoded. And so probably it is not always possible to say I love you. As many people cannot express themselves. That might be the condition. Patient could not express himself, what is happening in his chest. So that is why he just wanted to do an angiogram again and again. Even after doing an ETT, I just stopped all the medication. You should not take any medications because you don't have any risk factors. So we fixed up the lesion that was very tight, and we have taken fine cross to and also the hardware initially to cross the lesion, and then it was treated with a stent, and there is good flow. So case 3 is Mr. AM, 42 years, non-smoker, newly diagnosed case of hypertension and diabetes, presented in emergency department with chest tightness and sweating. Blood pressure a bit lower, family history nothing significant, and troponin level, it came later on, we could find 39,000. But previously we did serial ECG to see what is happening in his chest. Actually this is a case of acute myocardial infarction or not. There are some ECG changes in the V1 and V2. Look, and serial ECG we did, and it is something like that of Brugada syndrome, ECG, right? This is last ECG before taking the patient to the cath lab. So patient having still chest pain. Later on, we patient does not have any the history of palpitation or syncope. Patient does not have any family background of sudden cardiac death. Patient having typical chest pain, and then we have taken the patient to the cath lab. And where should we expect the lesion or at all? So this is left side angiogram, and there is no significant disease in the left side. Right side, it is totally occluded. So this is called Brugada phenocopys, are heterogeneous clinical entities with Brugada-like ECG pattern. Sometimes it is indistinguishable from the Brugada syndrome, maybe due to acute myocardial infarction, pulmonary embolism, or even hyperkalemia. Rapid identification of this condition in emergency department can increase the survival. The majority of the cases of the Brugada phenocopys in acute myocardial infarction have been reported due to RC occlusion, and very rarely due to LAD occlusion. So LAD occlusion could be there. So later on, we fixed up the lesion, thrombosuction was done, and we put a large stent. And this is the RCA ultimately. So never judge a book by its cover only. Need to see inside. This is very important. Thank you.
Thank you, Dr. Abu Muhammad Shafiq.